Good evening, ladies and gentlemen, colleagues and friends. Welcome to another session of SPG's webinar tonight on the topic of management of cracked teeth. Joining me tonight, as always, are my partners in crime, Dr. Chou.
Hi, good evening, everyone.
Dr. Zoe Potres.
Good evening, everyone.
And Dr. Agnes.
Hi.
Now, before we get started, I just want to say a word of thanks to all our referring dentists. Thank you so much for referring your patient to us, not just throughout the years, but also during these testing times. We deeply appreciate your referrals and your trust in us to look after your patients. So if there's ever any concerns, any questions, any hesitations, please do not hesitate to reach out either to me personally or to the practice. We are here to help out you and your patients. We do not take your referrals lightly. Tonight's webinar, as you know, is going to be, again, for roughly 2 hours in duration. So for CPD, please scroll down to the bottom of this page that you're on to complete your details, your email address to receive a CPD certificate, because if you haven't done that, you won't be automatically given a CPD certificate. As always, tonight's session is live and interactive, and that means for the viewers, all the viewers at home tonight, please do send through your questions. There's already a number of questions being sent to us already, so feel free to key in those questions, and I'll do my very best to direct all the questions to the panel. And as always, we almost always get an overwhelming number of questions, so we won't be. So my apologies in advance that we won't be able to cover every single question, but I will do our very, very best to address as many as possible. Slightly different to our usual setting, because that we are in an unprecedented time with really a lot of difference in opinions, particularly during this COVID period of time. Now, we certainly as a group, as a practice, as a business, we do take spread of COVID-19 very, very seriously, and we do take New South Wales Health's directions very, very seriously. Originally, we thought we were actually going to cancel tonight's webinar, and then later on we thought maybe we could try to make it happen through our homes. We just simply dialed in into the studio via remote and then broadcast this event. But given the time that we're at, and it's sort of right in that sort of dinner time where everyone is sort of at home watching Netflix, we've had a lot of issues where it's either the audio quality is nowhere near good enough, there's lag, sometimes there's even dropout, so that just simply wasn't happening. And we didn't want to give you something that's of not appropriate standard or quality. So we thought that we had to come into the studio to make this work. To make sure that we are going to be safe for each other and for others that's in the group, including Mr. Brett Taylor, who's at Articular Media, carrying out the session tonight. We've done the following to ensure that for everyone's safety. So firstly, we've all got ourselves tested over the last 3 days and received a negative COVID-19 result. Secondly, everyone on set here, including the presenters and Mr. Brett Taylor, we're all fully vaccinated. In terms of mask use, we're all wearing masks right up to the point of presenting. And as you can see, we've instead of being sitting on one large table, we've actually really separated ourselves out tonight in different corners of the room to be in compliance with social distancing rules. Another quick pointer on sponsorships. Previously, there was another question raised to me previously about sponsorships, and I just want to make it clear that the sponsorship that we're receiving is purely to cover the IT cost of running these sessions. None of the presenters here are being paid to do this. We don't have any financial interest from any of the sponsors, and we're certainly not being benefited from any of their products or services. So I just want to make another disclaimer regarding that. So, of course, tonight's session is not possible without our sponsors. Many of you would know that Noble Biocare has been a long-term sponsor of mine in terms of continued education. In fact, for just a little bit over 10 years. And this year, of course, is going to be no different, and I'm sure in the years to come. The N1 implant, that's the one that you're seeing on screen, has a very unique surgical and restorative platform, something that will be released in due course. So definitely watch this space, as this product will be revolutionizing these both surgical and restorative protocols. Credible, as you guys all know, our lovely finance company, Sandy and Teresa from Credible, lovely people to deal with, lots of experience now, perhaps more than ever, to reach out for a loan due to our unprecedented low interest rates. Kerr is certainly a household name when it comes to restorative and endodontic products. Over the previous webinars, we've introduced a number of very interesting bonds and materials that's suitable for certain clinical situations. And last but not the least, Experian, who are really, in a way, specialists in helping our dentists with their insurances. They've also been around for over 15 years. Due to some recent changes that's going to take place in October, where the previous policies, they're going to have some major changes in policy. So now is a terrific time to either to renew your previous policy or to take out new policies, because premiums are likely to go up. So it's a great time to perhaps renew it to how to soften that blow. And I've also been informed that claims have almost doubled during this lockdown period of time. So also it's a great time to review your policies to make sure that you are fully covered. And the principal, Mr. Mark Sachs, is certainly the man to go to either review or take up your policy. And just a quick plug about ourselves, Sydney Prosthodontic Group, for the ones participants that's joining us for the first time this evening. We're a prosthodontic group that's located in Chatswood, offering a full range of restorative and surgical services. We pride ourselves not just on providing your patients with the care they needed, but also to help you, our referring dentists, to achieving your goals, and so to help out with whatever concerns that you may have. Over the years, we've conducted hundreds of hours of CPD just like tonight to share with you what we have learned as a result of treating your patients. We are very passionate about continuing education and to help out the profession. So if you ever have any questions or concerns about anything that you may have, please do please don't hesitate to reach out to ask your questions or queries with the collective resource that we have on hand. We're certainly capable, I think, of addressing most of your concerns. So let's get on to our topic this evening, which is management of cracked teeth. Now, the reason why we really wanted to discuss this topic is because it is a very common clinical situation. Perhaps, especially during this period of time, there's a lot of stress, a lot of clenching, a lot of grinding. We certainly received our fair share of referrals for either a second opinion or for an assessment or for management of these situations. What makes it potentially complex is that the presentation in terms of symptoms are highly varied, and in terms of the diagnosis can also be complicated and sometimes not so straightforward. And that's why I think a lot of clinicians have struggled now with predictable management of these situations, and that's why we decided to hold this very topic. So we're going to be covering a lot of different aspects tonight, in a very short period of time, involving different classifications, different types of clinical situations, and how to manage them, what's the best available science out there. So perhaps we're going to start off first by looking at how do teeth crack? So Agnes, do you mind to take us through why do teeth crack?
Okay, sure. All right, so basically a tooth can experience a crack initiation or suffer from a fracture upon impact via a stress concentration that has broken the surface of the tooth, and with subsequent repeated loading, and this is a chronic nature, the crack can propagate towards the internal aspect of the tooth. This situation looking from a physics perspective, if you really want to study the different types of crack that can occur, can often happen with the crack initiation internally as well. It's not as commonly presented, and it is more difficult to diagnose in those situations. But then once the crack is initiated inwards, it radiates onto the exterior aspect of the tooth. This type of chronic crack is what we would be focusing on with the presentation tonight and the clinical management. However, of course, there will be some slight overlap in the coverage of accidental injury that would lead to a complete fracture in the one strong impact at the one time. Commonly, clinically, we used to see is internal stresses that are related to dental management. And commonly one of the examples is back in the days when we used amalgam restoration, whereby the philosophy was still to leave quite sharp internal line angles once upon a time, we know not to these days, is that like the electromicrograph you see here with the black circle, that is the weakest link where you can have a crack initiation. And due to thermal expansion of the amalgam or functional loading of unprotected cusp, you can then see from, depending on the stress plane and the direction of load, as the tooth flex, then that crack can potentially propagate. Whenever the bending moment is stronger, it tends to take a more oblique fashion, and quite commonly we see the undermined cusp ending up in a fractured cusp scenario in these cases. But in a nutshell, it's always a balance between forces versus teeth. You may have physiological type forces with your classically sound dentition throughout a youngest person's life until they age or certain other parafunction. We're going to talk about where sometimes you can have excessive forces, and sometimes you can have weakened tooth structure, and all it takes is that tip of balance, and the patient may be more at risk of having crack development or fractured teeth. So type of excessive forces that we classically see, many of us will already know, are parafunctions, bruxers, classed by the typical presentation of the hypertrophy in the masseter muscles, the mandibular notching, habits such as crunching on ice, gold restoration that create a lot of seating pressure, or where there is some misfit or very tight fitting, and as you press the restorations in. And but some other situations that I want to highlight that is not spoken of as much, but is very, very critical in a prosthodontic rehabilitation, or when we look at patient assessment, is looking at the number of occluding pairs and function. This PA radiograph that you see here is actually of an elderly lady who is in her mid-80s, and the opposing dentition is actually a full denture. Nonetheless, as she's losing more posterior teeth to contact, and she's got very high parafunction, and even though this particular distal molar looks as though it's got reasonable attachment loss, it is actually very firm with no mobility. And subsequent to a lot of tipping forces mesially and very, very occluding forces, you can see that she ended up with a horizontal root fracture down where the impact line of where she clenches and pushes her jaw forward. Other cases, even in dentate scenario, certain malocclusions such as open anterior bite, where now the number of occluding pair paired up with a very strong function is now only resting on those few molars, both in a tonic clench as well as any interferences during the parafunction. Obviously, these can be sound, healthy teeth, but under excessive amount of forces, even though you may think that it's all physiological. It's not uncommon to experience certain level of clench and grind, but not when you have certain malocclusion that only result in all the forces being upon one or two teeth. And here you can see that it's not uncommon to see crack symptoms on a single second molar when that is the hyperocclusion that you see in the patient. Many of our audience tonight would have seen this video that I'm about to play, where it's one of the patients of Dr. Bentley. He's a very chill, very easygoing guy who didn't think that he had any sort of level of stress or being in sort of any form of daytime parafunction. A lot of people might think that parafunction is related to external stresses in life, and it's not that uncommon to then, once you make the connection, to pay a mental note. In this man's job, as every time as he chops the barbecue, he clenches his teeth. And these are not external stress factors, but they're certainly helpful, though, to be able to identify these. So balancing excessive forces that we've sort of spoken about, what about weakened teeth? So we know commonly, but just a quick run through, if teeth have been restored, lost marginal ridges, they obviously would weaken the tooth. Looking at the width or the isthmus of the restoration, any cusp being undermined, endodontically treated teeth, depending on the amount or style of mechanical preparation during the process. But one of the aspects that you will find also when Zoe later on goes through the prevalence is that even pristine dentition in aging dentin, it is very important to acknowledge that if you compare young, youthful dentin of under 35 years old to the dentin of those who are older than 55, the older age group is basically half as strong as when they're young in under 35. Now we suddenly all feel like there's a ticking clock in us. And the amount of force it's required to snap that dentin is down to 1/4 that is required. So while it is fabulous that our dental population are more dentally aware, maintaining their teeth for longer, it is also not uncommon to see these aging dentition merely being restored, having incidences of crack or fracture after the age of 55. So here we have a photograph of endodontically treated tooth, beautifully crowned. But sometimes these are the scenario where by the moment of stress now, as there's the bracing force coronally, sometimes that force initiation will begin a crack down below and work its way upwards, and here we see a classic example of vertical root fracture. So I'm going to pass on to my colleague Zoe, who's going to talk to us about incidences.
Thank you, Agnes. So looking into incidence of cracked teeth, and it's been reported that people over the age of 30 are most commonly affected by cracks. However, adults of any age group may be affected by cracked teeth, depending on their lifestyle habit. We saw earlier habits such as biting on hard objects, ice crunching, clenching. It all can contribute to increasing incidence of developing a crack. Teeth that are heavily restored, especially with restored marginal ridges. In fact, it's been reported restored teeth have 29 times greater risk of developing a crack than unrestored teeth. So even healthy teeth, they've been reported to have varying reports in the literature between 13 to 74% risk of cracking. So what happened with the unrestored teeth? There's a study by Rod and Lee in 2006, and they actually did a collection of data over 1 year. They looked into all the patients that attended the hospital setting with cracked teeth, and they analyzed which teeth were restored and which teeth were not. So they had 154 cracked teeth, and actually close to 90% of those teeth were actually unrestored or minimally restored with a class 1 restoration. So we know that sand teeth may crack, as well. Looking at that upper premolar, there's a horizontal crack that's running through the midline, the central part of the tooth mesiodistally. So why do teeth crack? Anatomically, for example, looking at the upper maxillary first premolar, it tends to most commonly crack in a mesiodistal direction. And the reason for that is partly due to its anatomy, which has a bicuspal occlusal form. There is a reduction in the coronal radicular bulk because of the presence of mesial canal fossa. There's also a root furcation. So these teeth, upon trauma from the opposing dentition, whether it's a traumatic injury, where a sudden blow to the jaw, or someone inadvertently bite on a hard object like an olive pit, it may be enough to create that crack in that tooth, and it may lead to catastrophic fracture. So looking at Lubesi, have done a review of the literature. They analyzed 12 clinical studies that reported on the incidence of cracks developing in different teeth in the mouth. And they found out of that, as a mean value or a median value of those, 48% of cracked teeth were actually affecting the mandibular molars, followed by 28% affecting the maxillary molars, 16% affecting the maxillary premolars, 6% mandibular molars, and 2% affecting the rest of the dentition. And again, this comes back to the anatomical factors. So we know maxillary molars are a bit more robust. They've got the transverse ridges that gives them some structural reinforcement, but they also have the palatal cusp, which can act as a plunger cusp, occluding onto the steep or deeper central forces of a mandibular molar. And the wedging forces from that plunger cusp may lead to separation of, especially if the tooth is heavily restored, or even sometimes in unrestored teeth, it may lead to creation of a crack and then separation of those. So I'll pass it on to Ben.
Thank you so much, Zoe. I mean, looking at those incidences, I mean, 48%, which is mandibular molars, makes you just want to put a gold onlay on every single lower molar. I'm simply kidding, ladies and gentlemen. Do not take what I just said as a matter of fact. But I think it really puts into perspective about treatment planning. If you're dealing with a symptomatic lower molar, and especially with some of the other risk factors, like what Agnes was saying before, showing that case with a large anterior open bite, where you only essentially got contact on a couple of molars. And then on top of that, if that lower molar is symptomatic, I mean, you really have to take all of that into consideration in terms of what sort of restoration to offer the patient, and what is the prognosis of the tooth moving forward. So I am going to jump the gun a little bit here by asking Johnson this subsequent question by looking at whether all teeth with cracks needs to be managed or not, because we're going to then explore deeper and further into all the different classifications of teeth, then looking at cracked teeth, looking at which needs management, which doesn't need management. But the reason why I want to just have a sort of blanket, a little quick discussion on that at this stage is because often we do get referrals for second opinions and asking for, does this teeth need management or not? So I thought it's not a bad thing just to quickly cover that before we move forward. So Johnson, again, just to repeat that question, which is, does every single tooth with a crack needs to be managed?
In a general, I'm not sure. No. A crack can be the best case scenario of a craze line, which is a superficial crack in the enamel, which is in the canine. But the main reason this patient was referred to us is because of the crack in the composite crown in the premolar.
That might not show the images.
Okay. Yep. Okay. Yep. Yep. Okay. So due to insufficient ferrule, so that's why the patient was being referred. So the tooth has been endodontically treated, and there's just not a lot of ferrule above the gingival level. So when managing this kind of case, it's always important to let the patient know there's whether there's a daytime parafunction or nocturnal bruxism, it's very important to have an occlusal splint for protection at the end of the restorative management. So, but also very important that the first appointment is an investigation to ensure the crack haven't cracked too deep, so the tooth can still be salvaged. And the most common reason for recommending treatment would be compromised tooth structure. How likely am I be able to crown this tooth for now, or how likely will the tooth become unrestorable if I choose to have no treatment? Painful tooth or sensitive tooth, and in this case, there's a caries lesion associated with a crack, and hence very important for management. On the referral dentist also want to seek my opinion on another couple of cracked teeth on the mandibular molars as well. As Zoe has mentioned, mandibular molars comprise about half of the all cracked teeth. So while cracked teeth can be relatively stable, however, a small percentage, 12%, the crack to progress, and this is especially in teeth with multiple cracks, which is the case in the first molar. The tooth can also become symptomatic as well. 10% to report increasing pain symptoms after 1 year. So it's always very important to inform the patient that, so they can make the ultimate choice, whether some people prefer to do preventively, some people prefer to do it when the tooth cracks, but it's important to let them know it could become symptomatic, or the crack could become worse over time. And for this patient, the patient just wants to do one tooth at a time, just to maximize the health fund benefit. And after I've done the crown, the patients refer back to the referral dentist for occlusal splint and then management of this teeth.
Thank you, Johnson. So we will go in detail about what Johnson essentially just said in a very short period of time in terms of craze lines and cracks and which teeth needs management and which don't. So we move on to to a little bit of classification, a little bit of history. So we're going to start off from the term cracked tooth syndrome. I'm sure all our audience tonight have heard of this before, or CTS for short. Now, this was first this term was first coined in the 1950s. Where of course we all know that it's sort of a common symptom or collection of symptoms where the tooth is usually there's some sort of discomfort upon pressure, whether it's during biting down or release of that pressure. But over the years, with looking at cracked teeth, the symptoms of a cracked tooth is not only necessarily can be covered using those symptoms alone. For example, some cracked teeth may involve the pulp. So some of them may have, say, reversible pulpitis or irreversible pulpitis. Now, some of the cracked teeth may extend into the radicular region that may have some sort of a periapical, so a radicular or periodontal symptoms. While others, in terms of severity, could vary between one another. So therefore, there's a lot more complexity to the symptoms and presentation and severity of cracked teeth. So therefore, by using this one sort of a blanket term alone, simply cannot describe for all the cracked teeth out there. So partly because of this, according to the American Association of Endodontists, they have published an article called Cracking the Cracked Tooth in 2008, which gave a classification into 5 separate categories, which I think is being widely adopted and accepted by most endodontists. So I'm going to quickly go over these 5 categories, and then we're going to break these down, one segment at a time, or one category at a time, to look into what are the literatures out there and what could be some of the management protocols. So starting from the first category of craze line. So Johnson started off with that. So you can just see indicated by the little red arrows. There's a couple of them, one on the distal of the canine and a couple on the premolars. So these look like crack-like. Usually they're sort of vertical in nature. It can be in either anterior or posterior teeth, very commonly found in most adult dentition. I think it will be hard not to find them in your senior sort of patients. The majority of these, of course, are not symptomatic, so therefore the majority of these I do not believe needs management. For the viewers at home, if you're wondering, well, how do you know that's a craze line, not a crack? How do you know that's somewhat superficial or not very deep? Of course, there are a variety of different ways of investigation. Using transillumination device is one of which. For the picture on the left is when the light, when it's shining through that craze line, the light you can see is still diffused and passing through that craze line. Whereas for the image on the right hand side, when the transilluminator is passing through the cracks, because the crack is deeper, so therefore the light is reflected, and therefore you get this shadow beyond that crack. So that's a very sort of simplistic test of looking at what's craze or crack, but we're going to go into detail in a moment. The second category is called fractured cusp, where one or more of the cusp has suffered, whether it's an incomplete or a complete fracture. That's again, it can be above or subgingivally. Category number 3 is called a cracked tooth. How original. That's the crack starts from the coronal section, and then it's traveling down apically. It could be into the pulp, it could be, or may or may not into the pulp, or may or may not into the reticular systems. But it starts off from coronal and going down towards the root apex. Category number 4, it's almost an eventual development of category 3, which is a split tooth. So this again starts at the coronal level, but extending pretty much right throughout the entire tooth. And section or category 5 is called vertical root fracture, which is the other way around, as in the crack initiated from the apex and is moving towards the coronal level. Very often this term is referred to teeth that's endodontically treated, and therefore there is an easier stress factor that could concentrate from the apex. So looking at these 5 categories, we've already somewhat said that the category 1 of craze line, the vast majority of the times does not need treatment, whereas a split tooth, category number 4, I don't think many people can salvage those situations. Category 5, vertical root fracture, I think it really depends. Hypothetically, in a multi-rooted case, perhaps removal of one root, so like a hemisection, maybe possible. So that's why I put in the word not treatable, or potentially, or most likely not treatable. Furthermore, most of the times these management are either carried out via some sort of surgical means or perhaps complex endodontic procedures. So those sort of treatments is outside our discussion topic for tonight. So for the majority of tonight's session, we're going to be covering the second and the third section on fractured cusp and cracked tooth. So I'm going to pass you over to Agnes to go over with us on the top of craze lines. What are the other ways of diagnosing, and perhaps most importantly, how do we prevent these craze lines from worsening perhaps into a cracked tooth?
Thank you, Ben. So actually this topic has already been defined. So a craze line is the initiation of this potential crack, but it's very hairline thin, and it is within the enamel layer, has not yet reached the DEJ. Once it goes beyond the DEJ, it is basically where it is now a little bit more vulnerable, undermining the tooth structure, and we begin to describe it more as a crack. And the way to diagnose it, I think Dr. Lee have shown it really well previously with the transillumination, to really just have a look whether how that craze line or potential crack diffracts the light. So commonly they are just observed as striation on the teeth, if they are asymptomatic and if they do not pose any aesthetic concern, we do commonly leave them alone. Having said that, it's not to just say we do nothing about it. No, because the reason why they exist really it's its own story for us to tell. Looking at these two photos here, just want to share with you, as Dr. Lee described, many of these craze lines we do observe in our day-to-day patient. Many a times we do not need to treat. The reason to treat is not merely because of these presence. We have to look at aesthetic function preservation. When we assess these craze lines, if you focus on the upper photograph, and if I were to ask you to just have a look at that 1-3, that vertical craze line goes all the way to the cusp tip. And now look at the 4-3. If you imagine this particular patient going to excursive movement, I can assure you that those two vertical craze lines marry up. What these craze lines do tell us is that this is how the patient's forces are happening in those dentition over time. If we ever were to consider having any restorative need for this patient, commonly, so when it goes to the second scenario, that bottom picture, if the crack becomes stained, or it gets a bit deeper, maybe still asymptomatic, but now you want to consider doing something for the patient, we do have to pay attention to where these craze lines once were to give us some clue on what are the forces that is upon this tooth, so that we can balance those views and take that information in our restorative design. Later on, I will share a case with you that talks a little bit more about it. But I just wanted to say that instead of just close file, do nothing about this category, it does tells a story, and it does give us some information about what's happening. And we should always caution the patient just to bring to their awareness the amount of wear and tear, at least, that are going on, to educate them and raise the awareness. I will pass to my colleague to talk about cusp fracture.
So now Johnson is going to talk about the second topic, or the second category of fractured cusp. So over to you, Johnson.
Yep. So the management is depending on where the fracture is. In this case, the fracture was also subgingival, and also you must ensure there are no crack in the mesiobuccal cusp if you decide to preserve the cusp, which is the case here, and then is test with the crack finder to ensure tooth slope, to ensure the tooth is not symptomatic. So the options, this patient had a repeated fracture, so a patient decided on gold restoration. So here, Dr. Lee has made some mechanical retentive features, including a groove in the mid-buccal region, and also to ensure we embrace the tooth as well. And gold onlay was placed. So gold onlay is also beneficial when the fracture is subgingival as well, because when it's subgingival, I'm always concerned that there's insufficient enamel to bond to if I choose ceramic. And the other option would be a more ceramic option, because although we like to use gold, but most patients doesn't like to have gold in their mouth. So in this case, this was a supragingival crack of the 3.6 and 3.7. So first, amalgam restorations are removed, and then we can see that the one of the mesiolingual cusp on the 3.7 is basically undermined. So it's very important to involve that cusp as well, and then we use a double cold resection technique, which is done by Dr. Lee. So first, usually like to use a 000, and second one 0 or above, making sure all the impressions goes beyond the margin. And what's done in this case is with inlay, onlay veneers, there's always a high risk or increased risk for the provisional to come off. So in this case, it was splintered, but always have to make sure that you put some grooves near the gingival portion to ensure Pixter can still go in to clean the area. And Emax inlays, onlays were placed. And then here's the result. But what if the fracture is subgingival, which is this case? So in this case, we do offer the option of what we call a long bevel crown. So basically, we utilizing the space, the ferrule between the gingival level and almost to the crestal level of about 360 degrees circumferentially. But of course, we do tell the patient that the prognosis, of course, is not like a good crown which could last 10 or more years. This could up to 7 years. But some people still prefer to save their tooth compared to elective extraction of the tooth and implant placement. What about the fracture is deep subgingival? In this case, is referred by the periodontist, and there was a pre-existing CBCT for the implant on the other side. So in this case, there is sufficient ferrule at the mesial, buccal, and lingual. But however, at the distal region, is about almost to the crestal level. So the ferrule you want to is 360 degrees. So in this case, there wasn't sufficient ferrule at the distal region. So different options were discussed. One would be orthodontic extrusion and also orthodontic intrusion of the opposing molar, which is challenging, but the patient has rejected. One could be a crown lengthening, but of course you could be removing the bone that's required for future dental implant placement should this tooth fail. And then one, of course, would be elective extraction and dental implant placement. And it's a discussion with the patient. The patient have the ultimate say. In this case, the patient feel he's after something a bit more longer term, so he's elected to extract the tooth and then have a dental implant placement.
Great, thank you, Johnson. So ultimately, I guess there's a few number of points that you raised. One is how much, or where is the position of the fracture, and how easy it is for you to restore the tooth. And I guess for the supragingival cases, wherever possible, we've placed some sort of an onlay type of restoration instead of going straight to the crown, wherever possible, as long as there's enough retention and resistance form to be more on the conservative side of things. Wherever the case got a little bit more complex and reaching that sort of subgingival portion, sometimes in onlay may be complex to achieve sufficient retention and resistance form, and therefore we've elected for a crown, whether or not utilizing a subgingival margin format to optimize the ferrule effect. And then for the very, very deep subgingival type of fractures, then additional options have to be presented to the patient, right? Whether it's extrusion or crown lengthening, or even the extraction. So no, thank you so much for covering a quite a potentially complex situation. So moving on to the next category, which perhaps is one of the most challenging one, which is the third category of cracked tooth. Zoe, could you take us through how to really diagnose it? Because a lot of people struggle with that, and ultimately, what is your management protocol for these teeth?
Thank you, Ben. Certainly, diagnosis of cracked teeth are very challenging at times because it's the symptoms of the patient presents with varies a lot. Sometimes they are symptomatic, and sometimes it's really asymptomatic. So therefore, we'll really need to carefully look into any history. So past dental history, past trauma, any incident where the patient has report or recall that might have contributed to a traumatic event to the tooth. And also looking at what sort of pain the patient's reporting. commonly with cracked teeth, sometimes the patient report that certain positions where they starting to chew certain food, it may create pain, and it's only repeated in certain positions through that chewing cycle. And sometimes they come up with cold sensitivity, and which can be very confusing because we have to distinguish, is that something to do with dentine hypersensitivity? Is it a crack on the tooth? So most symptoms are really just relating to the cold sensitivity and the pressure or pain on release of that pressure. So to start with, we can look into a visual inspection of the tooth. Using magnification, explorer, looking into any presence of defective restorations, perhaps might be able to visualize a crack lines on the marginal ridges or alongside the restoration. Also assess the patient occlusion. So in lateral excursive movements, using a shim stock or articulating paper, we might be able to pick up if there's any posterior interferences with one of the cusps in one of the excursive movements. And then once we able to visualize that, we can move on to pick up on some diagnostic tests. So percussion tests, most teeth are with cracks, if they can be tender. If you do the percussion test at an angle, it may, at an angle to the tooth, it may actually lead to the flexing of the cusp and the fluid, stimulate the dentinal fluid to pass through, and they may create or reproduce some of the symptoms the patient's been reporting. Also vitality tests. So vitality test is not really used to detect a crack, but it's definitely will give us an indication of the status of the pulp. Periodontal probing. So sometimes when there's a crack, we might be able to, if the crack extend to the crestal bone or beyond, we might be able to find a localized pocket, and that can be a good indication for a crack. Radiographs for our daily practice, usually, unless if they're running in a buccolingual direction, where the crack might be running in buccolingual direction, radiographs are very difficult to visualize a crack, because most of the cracks in mesiodistal direction, they're running on the same plane of the film, so it's very difficult to diagnose. All right. Okay. So once we have identified in the patient mouth that there's a crack and we suspected a tooth, we need to confirm that this is the tooth that's giving the patient symptoms, and we can do that by doing a biting test on tooth sleuth or frag finder. So a pain on pressure on release, and if we need further sort of diagnostic tools, and we're suspecting a tooth but we can't be quite certain, a stainless steel band or an orthodontic band, if we use it to stabilize and splint the tooth, the patient can be sent home, and if the symptoms have resolved, that will also aid in the diagnosis of that cracked tooth. Okay. So what happens with the, why do we get pain on release of pressure? So normally when there's a cracked tooth, there's a dentinal fluids are usually at equilibrium, so the tooth is symptomless. As the patient bite onto something, it tends to flex that cracked cusp, and it opens up the crack, so that leads to flow of that dentinal fluids into the crack, so they fill up that crack, and as the pressure of the biting is released, there's a rapid closure of the cusp back into place, and that tend to forces the dentinal fluids into the pulp, leading to symptoms, patient experiencing that symptoms or pain on release. Okay. Okay. And we can use other diagnostic tools. Definitely, if you're suspecting a tooth has a crack, then it's time to look into, under local anesthetic, removal of that restoration, with the aid of magnification, you can see or visualize where the crack is extending to. So inspect the mesial marginal ridges, distal or the pulpal floor, or any cusp that might be that is still present. The stains and dyes might be used as well, and sometimes they are helpful detecting a crack. Ben mentioned earlier transillumination. So transillumination, very useful to detect the crack. So the crack that kind of penetrates, so it's not the craze line, but it's the crack that goes through the enamel and also extending into the dentine of the tooth. As the transillumination penetrates the tooth, is actually the presence of that crack disrupt the light transmission. As you can see in that lower left molar, the transillumination on the cusp is actually interrupted in the middle between the two cusps, and that's where the crack actually lies. And if we do this, preferably we can do it under rubber dam just to improve visibility. If you don't have a fiber optic transillumination light available or handy in practice, sometimes even the blue light that we use for light curing composites might be useful as well in detecting a crack. So I'll pass this case on to Ben. This is a case that he's done with Mehdi Rahimi, an endodontist. And I think, Ben, my understanding, this tooth was symptomatic endodontically treated tooth.
Yeah, thank you so much, Zoe. Mehdi told me he was going to watch tonight, so he might be quite proud of me showing his case. So this is Mehdi's case, and obviously it's an upper molar, 1/6, that previously with the history of endodontic treatment as well as a crown, and it was suspected of having some sort of cracks or that's extending into the tooth. So Mehdi showed me his whole entire video collection on the management of this tooth, involving very skillful removal of the crown at first, and then so he here in this video you'll see that he's using a transillumination device, firstly externally examining the tooth, looking for potential cracks before he's going to get into the tooth. And then he has removed the composite core and internal restoration, and now he is going to increase his magnification, and now he's going to use his lightsaber going internally, looking for cracks even further. So here visually we can definitely see there's a vertical crack that's going down, and as he's using this transillumination device from different angles, you can now see the crack is actually now running through the floor of the pulp. So this has significantly improved the visibility of that crack. And because of that, of course, then you have to let the patient know that the prognosis is now questionable or compromised, and that would definitely affect his decision-making process going forward. So thanks for that, Mehdi, and I'll pass you over to Zoe again to continue with once we have found that crack. Well, what are we going to do next?
Okay, so definitely early diagnosis is important. So we will need to decide on to be able to assess the restorative management of that tooth. We need to do the extension of the crack, whether there's a pulpal involvement, or is the tooth worth keeping. Okay, so in terms of direction of crack travel is one of the things that we need to inspect. There's three directions: one horizontal, oblique, and vertical. So if the crack is extending horizontally through the enamel, it usually has an excellent prognosis. However, once the cracks start to go in an oblique direction through the enamel and dentine, we tend to expect a slightly more moderate prognosis. As the crack progresses down toward the pulp, we have to warn the patient that the tooth will probably require endodontic treatment, and the prognosis is even jeopardized. Vertical crack involving the root, and I'm sure a lot of endodontic colleagues might be able to still treat that tooth and preserve it for a number of years. But we still, nevertheless, have to warn the patient that we don't know how long this tooth will survive, and it is heading toward a more poorer prognosis. So when we assess the tooth, once we identified there's a crack, so we need to distinguish between does the tooth require endodontic treatment, or is it just a simple reversible pulpitis? And again, I know everyone is probably everyone is aware of this, but just as a reminder, the difference between reversible pulpitis, where you get a sharp, immediate pain that disappears quickly after removal of the stimuli, it's a bit more localized, it shows no normal response to the pulp testing, and the tooth is normally not tender to percussion. Whereas with the irreversible pulpitis, we're heading toward more spontaneous, persistent pain that lasts a lot longer. It's not localized, and even with pulp testing, we end up with a marked and prolonged response. Early stages still not tender to percussion, but as the periapics became involved, then with the necrotic pulp or periapical infection, then we end up with a tenderness to percussion. So what are the treatment outcomes? Now, when we looked into whether the tooth is vital or non-vital, so we've discussed some treatment outcomes as been reported in some of the studies that I've looked into. So this one is for vital teeth, and it's a clinical trial by Crowell and Rivera in 2007, and they had 127 teeth that has been diagnosed with reversible pulpitis. Now, all of those teeth were treated with the crowns, and they did a 1-year follow-up after crown cementation. And they found that restoratively, the teeth were successful. All of the teeth were retained at that time point. However, 20% of those cases did require endodontic treatment due to non-resolution of symptoms or developing of necrotic pulp or irreversible pulpitis down the track. Another study by the Wu in 2019. It's a retrospective clinical trial. They also looked at 199 cracked teeth diagnosed with reversible pulpitis. They initially managed them by placing orthodontic bands and then referred for crowns. So not all the teeth have ended up receiving crowns. Some of them did, some of them did not. And at a 3-year follow-up after diagnosis, they found that 71% of these cracked teeth were symptom-free and remained healthy for 3 years, whereas 29% had some sort of pulpal complication. Between some of them developed irreversible pulpitis or pulpal necrosis, and they usually found that this occurred at about 1.2 to 2 years after crown cementation or initial treatment. So what they recommended is having a full coverage restoration tend to improve or minimize the flexion of the cusp, and it tend to minimize the pulpal complication. This study looked at the root canal treated teeth. Lung 2020 is a recent systematic review. They looked into endodontic treated teeth that had cracked or had some sort of cracks, and they were treated. They found that the overall survival rate of those teeth was 84% at 5-year time frame. And they also reported that teeth where the cracks have extended to the radicular area experienced 9% greater risk of being extracted, as opposed to teeth where the cracks were only confirmed within the crowns. All right. So in terms of what's been reported as 4 main factors that dictate or whether have some sort of a clinical importance, when they looked at the study of the endodontically treated teeth, they found that the direction of the crack was important, as well as the extent of the crack. Teeth that had multiple cracks experienced about almost 10% higher risk of extraction as compared to teeth with just one single crack. If there was increase in pocket depths, It was a they considered that as one of the prognostic factors, increasing the risk of failure than those that did not have an increase in probing depths. Being a terminal abutment also exposed the teeth to higher occlusal forces compared with teeth that are a bit more interior, and those teeth tend to have 8% more risk of tooth loss than non-terminal abutments. So this case I'd like to share with you. It was done at our practice with a patient who presents with really concerned with the aesthetic and of her two central incisors, and she was also concerned that are my teeth going to crack? Seeing those two crack lines and that becoming increasingly more stained with time. Now, those teeth were vital, and there was no indication of increase on probing depths. So there's give us some sort of hope that the crack has not extended to the crest of the bone. But it was very difficult, almost impossible to determine the extent of the crack. So addressing the patient concerns in terms of improving aesthetics and preserving the structure and integrity of those teeth, they were prepared for, indicated to receive crowns. And following the preparation of the teeth, you can see that the crack line did not extend to the crestal bone. They were still contained within the crown structure of the tooth, and the teeth were vital, of course, at that time. Now, those teeth were treated with crowns, and there was asymptomatic during the temporization phase and then definitive phase. Following on that treatment, at the 5-year post-operative recall, you can see the gingival tissue maintained pink stippled appearance, appears quite healthy. There's still no increase in the crack hasn't propagated further, so there was no defect of increased probing depths, and radiographically the teeth did not require endodontic treatment at that 5-year post-op. So it was a very good outcome for that patient. Thank you, Ben.
Thank you so much for covering that, Zoe. It is a complex topic, but I think you did a brilliant job of that. And we'll come back and discuss more about that. Because I think this third category of cracked tooth is where a lot of the clinicians struggle in decision-making process. So we haven't finished talking about this topic just yet. Now, if you do have any, as these sessions are live, if you have any questions, please do forward, send them through, and I'll direct them to the panel for discussion. So one very common philosophy or question that's often being raised is if the tooth has a crack, do you chase it or not? So as in to chase or not to chase. And there seems to be two different schools of thought. Again, the opinions are somewhat divided. On one camp, it's where some clinicians believe that you should remove the crack. One such author an article by Prof. Paul Abbott, published in 2009 ADJ, certainly carries that belief. Now, it is the authors believe that cracks should be viewed as a biological problem, just as, say, dental caries or a defective margin where caries or bacteria could enter, and therefore a crack is also a potential pathway for bacteria which could enter the pulpal or the radicular system. Therefore, cracks should be removed. So in their article or in their study, they've looked at 100 cracked teeth, all showing reversible pulpitis. So this was their treatment protocol. So first, they removed all restorations, caries, undermined tooth structure, as well as removed, actually I should use the word eliminated, I believe was the word they used, the cracks. So that means they just completely chased the cracks, so to speak, and removed it. And during this process, they've decided to carry out 15 out of the 100 teeth they've decided to carry out a root canal treatments for. Now, out of the 15 teeth they carried out root canal, only, according to the author, only 2 of the 15 was because that crack has entered the pulp chamber. And the majority of the reason why they carried out root canal, it was more of an elective base, where after they removed perhaps a heavily restored tooth, they felt that structurally speaking, and able to put a crown on the tooth, that tooth may need a post. So therefore, the decision was made to carry out elective root canal treatment for the placement of the post. So the majority of the teeth, once again, that they root canal treated were elective. And then the remaining teeth, for the ones that did not receive a root canal treatment, they will have to provide some sort of a provisional, and they used a sedative dressing. So so they use, for example, a lead mix cement in the chamber, it's a lining agent, and then they use a GIC on top. The author did state that some teeth they did use a stainless steel band. However, that was only so that you could hold the provisional restoration. The metal band, or the idea of using stainless steel band is not to splint the tooth or to provide the tooth with protection, because they've already removed the crack, they already removed the undermined tooth structure. Some of the teeth, also interesting to note, that received a temporary crown, not because they have had root canal treatment, but because I think it was fairly structurally compromised. And what was quite interesting with the temporary crown is that they didn't use things like temp bond, like what we normally use. They've actually used IRM as the temporary cement, because it contains zinc oxide eugenol. Therefore, that material is like a sedative dressing for the pulp. So using that protocol of the 85 teeth that did not carry out root canal for, all 85, 100% of them, the symptoms resolved within 3 days. So I did find that quite interesting. And then they reviewed these teeth over a 3 months period of time, and further to that 85 teeth that were not root canal treated, 2 more needed root canal. One was because pulpitis came back, and one was because at the 3 months review level, they found that the pulp, it was pulpal necrosis. And eventually, all teeth received either an onlay or a crown restoration, and then they were reviewed at up to 5-year level. And during that period of time, only 46 out of the 85 teeth that were able to be reviewed. So basically, only about 50% of the teeth that were able to review, and out of that 50%, they found 2 more teeth have received root canal treatment during that time. So to sum up, you could say that using that protocol, a minimum of 20% of the teeth needed root canal treatment at some stage during that management, and the majority of which appears to have been received before the crown was done, and only a small percentage received root canal after the crown was done. And using that protocol, the survival rate appears to be quite good. I think, I guess one potential critique that some of the audience may make is that, well, that really depends on how deep that crack goes, wouldn't it? I mean, what if the crack was extending quite subgingivally? Then wouldn't you potentially either A, structurally weaken the tooth, or B, render the tooth potentially unrestorable? So I guess there is that concern of being perhaps a little bit too removing too much tooth structure, and therefore compromising the tooth structurally in the long term. And that's why perhaps this with the second school of thought, which is not chasing the crack or not removing the crack completely. And so this is a sort of this article was covered by Zoe a little bit prior, that Corral and Rivera study, and what's quite interesting about this is that also just roughly 100-something odd cracked teeth, also with reversible pulpitis, were treated, but they the treatment concept is very different. They just had a blanket statement of crowning all of these teeth. So there was no onlays, no nothing else. There were no description about the restorative protocol, as in how long do they receive the temporary crown for? Did they use a sedative dressing? Maybe what sort of crown material was used? Were they cemented using GIC or resin? We don't know a lot about how it was done. The authors simply stated that all of them just had a crown. We also knew that they did not remove the crack because the author stated that restorations or pre-existing restorations in the teeth were only removed if root canal was required. So in other words, these 127 teeth, they initially did not receive root canal, so therefore no restoration was removed. So after the crown were placed, 27 in total, in other words, 21% of all the teeth that they treated using that protocol needed root canal. So it's quite interesting that 21 out of 27, so the vast majority of those teeth needed root canal in the first 2 months, and the remaining 6 out of the 27 required root canal in the subsequent 5 months. And then at the 1 year recall, the rest of the 100 did not require any further root canal treatment. So I guess what I think is that with this particular study, if you were to simply fairly quickly crown a cracked tooth with reversible pulpitis, you certainly have to warn the patient that there is certainly a significant chance, 20-something odd % chance, that these teeth would need root canal treatment. And secondly, in terms of the material that you want to use for your crown, if you're going to adopt this protocol, you should consider about the material that you want to use, because at some stage someone has to make an endodontic access. So, are you going to say, for example, you're going to use a gold crown? That's quite favorable. Or you're going to use PFM with a gold occlusal island, and again, that's quite favorable to access, etc. So you have to have some considerations with your choice of material and a discussion with the patient about that. Another interesting point about this article was that the authors noted where these teeth that needed root canal were cracked prior to having that crown. More than 56% of them found the cracks only on the distal marginal ridge, a small proportion found them in the mesial marginal ridge, and about a third found cracks on both marginal ridges, which in other words means that it's actually very difficult to predict which tooth with what sort of crack is more likely to have root canal. And the second thing they noticed is that there were a few teeth that had increased clinical probing depth afterwards, particularly at the interdental area. So again, that's another thing to warn the patient that potentially cracks could propagate. It could worsen. So I guess before we go on to the next part, maybe we'll just do a quick summary of this segment of cracked teeth, just for our viewers to have a better understanding, because it's a complex issue, and the cracks can be shallow. It could involve the pulp. It may be keep on but more deeper. So there's various severity or presentations, and therefore our management might be a little bit different too. So maybe I'll start off with a question. It's like a round table discussion. So what if you got so we're going to start from the least severe, and then we're going to work our way down to the more severe. So what if we had a tooth that is showing, it is not showing signs of reversible or irreversible pulpitis, so there's no pulpal signs, but simply the patient is experiencing discomfort or unbiting or release. There's a crack within the tooth. How do you guys go about managing that clinical situation? And assuming that the clinical periodontal probing depth was normal, there was no deep probing depth. As a general rule, what is your thought process in terms of provisionalizing or eventually what sort of definitive restorations you may make for that particular tooth?
I think if you hypothesize such a case is actually quite ideal. First of all, I acknowledge the fact that you could visualize this crack which is very important because unless you can visualize it, that's the basic definition of diagnosing the presence of a crack. It must be able to be visualized. And on top of that, you have ticked the box of a reproducible clinical chairside symptom of pain on release of a bite. So when you tick both boxes, it is quite evident that you can report to the patient both visually with a clinical photograph and the representation, the reproduction of this pain on release, the direction of the crack. So that really is gold tick of educating and informing that patient. The next thing I would go really from there is to inform the patient of vulnerability and what happens if the crack continue to propagate. The basic treatment really from there I would is to try to minimize any flexion on the tooth, number one. Now whether that be adjusting cuspal contour to replacing potential restoration if there is already one, any type of minor management occlusal spleen, but basically counseling the patient on anything that can reduce the flexion and not to produce that symptom. Beyond that, I would inform them once we are able to make some positive changes on this etiologic factor whenever they feel ready, is to then decide on potentially crowning those teeth. To offer a better splinting effect, because the presence of the crack is already confirmed. It is only a matter of time that it will progress. The main thing is to do the minimum. I
think it was 13%, wasn't it, according to that study, that may progress after 1 year.
So, but I think correcting the etiology is very important though. So certainly not everything is just microscopically looking at the tooth. So certainly if we identify that there are occlusal issues, for example, the anterior open bite, and now it's just all on that molar, it is the time to bring up that conversation to the patient. Look, this tooth may need a crown, whether it is now or in the future. Would this be the time now for you to consider orthodontic management as well to improve this further? So, it is so important to actually find out the etiology, like the risk factor that have contributed in this scenario. I think I would approach it that way. And then certainly if you can find the improvement on symptom, the crown card's on the table, but it is not a definitive treatment. I don't like the word of treatment when it comes to crack tooth management, because it is never really the case to remove or repair this crack in any way.
Once it's cracked, it's cracked.
but there are ways to keep that functionality in the mouth if other things are addressed. But also, it's not often, once you see one tooth crack, often it's not the first one either. It tends to potentiate other ones, especially in a younger patient. So so with that hypothesis that you gave, we have a good start. We at least have a very good start.
Any provisional strategies? Zoe previously alluded to using potentially orthodontic band to try to help to either to confirm the diagnosis and also to reduce the flexion of that tooth, because potentially of these patients, quite often one of their main concern, the reason for attendance is when I chew, when I bite, I get this pain. Sure, there could be a subcontext of parafunction, but there is just a normal physiological functional component that they just can't chew. So what provisional methods may you use for that case?
You want me to? Are you going round table?
Oh, anyway, Johnson.
Oh yeah, I saw you mentioned orthodontic band. One is remove any of the restoration if the crack is underneath the restoration to investigate, and then orthodontic band and provisional restoration. That is a good cost-effective way, and then it's something that you could do in half an hour in the first appointment. But of course, not everyone wants to have an orthodontic pain in the mouth, especially if it's upper premolar, right? So, provided the crack is still supragingival, then you could place a composite overlay of some kind. A little bit more time, because often this takes about an hour. The other option would be provisional crowns as well, but often provisional crowns, they don't seal perfectly. So to seal well is either a milled provisional crown, or you bond your provisional crown in. Yes. So often, and the patient is committed to a definitive crown. So if you don't do a bonded or milled, it's often your definitive crown that does your diagnostic phase. Yes. But if the tooth fails, a patient might be upset because they spend quite a bit of money on the definitive crown already.
Yes.
Yeah.
Zoe, would you consider a different type of restoration? Both Johnson and Agnes cover crowns. Would you ever consider an onlay for these cases?
Well, definitely, Ben. I think if the tooth is asymptomatic and doesn't have signs of reversible or reversible pulpitis, but still vital, and the patient, we have definitely diagnosed the presence of a crack in terms of that pain on release, or perhaps biting on certain things that might cause or trigger the pain. And I can visualize the crack, then I think from my perspective is that I'll be looking into if the tooth is restored, definitely removal of that restoration. So to assess the extent of that crack, and if I can see the extent of the crack, my intermediate provisional treatment would be to minimize the flexion, and I'll be doing a direct approach of composite to start with, overlaying that crack cusp. So reducing the depth, the height of the cusp, and overlaying that to minimize the flexion. And this will be our diagnostic tool as well. The pain improves. The patient will have the option of actually going ahead and doing something a bit more definitive in terms of an onlay. So I'll be considering either ceramic onlay, depending on the aesthetic, or the occlusal factors, or even gold onlay if the patient doesn't worry about having yellow gold restoration in their mouth.
Yeah. Now, okay, so now we're going to increase the complexity of this case, right? So now it's still the same. It is now the same tooth, but on the other quadrant now, right? On the same patient. Again, you can see coronally the tooth is cracked, but now this tooth is showing symptoms of reversible pulpitis. But luckily, when you carry your your periodontal probing, there's no deep, discrete clinical probing depth. What would you do differently, or would you do anything different to what we already discussed?
I think it's important to report the pulpal status, to the patient, and the potential reason, not just for the crack now, but also the bacteriology of how it is now involving the pulpal symptoms. And also it is time to let them know that this is in relevance to the extent of the crack, and the possible likelihood of them having some periodontal symptoms in due course, and the potential of further extension of this crack if we do nothing. I often would inform the patient with quite clarity from the beginning that we are looking at an entity with a structural aspect, endodontic aspect, and periodontal aspect. Even though really from the patient's point of view, it's just how long can I keep the tooth in function in my mouth?
And can you get me out of pain? Because I'm in pain. Most patients come because of pain, right?
Yeah.
For these things.
So, but it's important to have clarity in those different dimensions, because you can then therefore let them know that depending on where they now sit, and with a reversible pulpitis and no pocket drop, we're still at that beginning, and the prognosis is reasonable, provided we can give it an early address. But again, control the etiology as well, where possible. and give them a very a frank outlook on what is to come. And while we are preserving the tooth structurally, are they the type of character that can still embrace the potential progression of the endodontic need or periodontic need as this story unfolds? Or, if they want a bit more certainty, well, how do you know how deep this crack is, even though it's not showing sign? And for some, and depending on the age group, before they spend the fortune on this crown, if their expectation for the crown is I want at least 10 years, 10, 15, 17 years, to them, then I would probably let them know that, well, if you cannot accept that somewhere along the way you're going to have an endodontic access, because it's 20% chance that you may need root canal treatment afterwards, you may consider bringing it forward to, explore this crack where possible. So, you bring up this conversation with the patient. Certainly, if there is a restoration involved to a certain depth, especially if there's a very old amalgam, I think it warrants the fact that we can discuss, look, we have to at least remove this restoration, perhaps with some full cusp or coverage restoration, and see whether this symptom settles down. You don't jump the gun to go, I'll just elective endo. Make sure that may be the next step. If it gets worse, your proposed scenario. And because, it is only with internal inspection at that time to give you a more fairer prognosis. Is there multiple crack? Does it involve the pulpal floor? And if it ticks all the boxes, you're just at a better starting point. The crack is pretty much still there too, but it's just give you a bit more confidence to go ahead to restore those things. So very involving with the patient.
Yes. So bring up the discussion of potential elective endo. Johnson, what would you do differently to address the patient's now pulpal concerns? Now with reversible pulpitis, from the provisional that you will construct, what would you do differently if there's any difference with the previous scenario?
With previous scenario, pulpitis, reversible pulpitis, with orthodontic band, basically rather than placing a provisional restoration, you could place a composite core material, just bond in the tooth a little bit better, and then with the composite overlay, just ensure it sort of have the bracing effect on the crack, as provided it's not subgingival, of course. And then with a provisional restoration, a provisional crown, unless the crack is subgingival, then there's also orthodontic band or provisional crown, but I'll be a little bit more hesitant because the incidence is 20% or to 29% in some of the studies. So I'm a little bit more concerned. But if the patient elect the option, it will be a more bonded approach to provide the best bracing effect. But of course, you have to explain to the patient, if our goal is to preserve the vitality, we may not resolve the pain in 20% of the chances where the patient may need root canal treatment. But if our goal is to eliminate the pain, then that's elective endodontic treatment in this case.
Zoe, would you do anything differently? Would you say consider putting some sort of sedative dressing or sedative temporary cement, especially if you're doing like a temporary crown or something like that? Because we're all concerned that you sort of jump the gun too early, right? You crown, or you provide the patient with expensive definitive dressing too early, and then the patient is in raging pain, and now they need to drill a hole through their lovely crown or onlay that you just did, and everyone now is upset, right? That's why we often all talk about how are we going to provisionalize these teeth, and what you're going to use, and then the next question is, well, how long do you sit on it before you make a decision, assuming the reversible pulpitis has been managed, has been addressed? How long do you wait before you may change that to a definitive restoration?
Well, if the tooth is so, there's two scenarios here. So we've got a crack. If the tooth has a restoration, and then perhaps it's an easier approach. You always warn the patient that, all right, we've got pulpal symptoms, and it may progress to irreversible pulpitis, and there's a crack. So depending on the microbiology or the bacterial contamination of the pulp, we don't know at this stage. But what I would suggest in this case is to remove that restoration, and depending on the time on that setting or clinical setting, I may consider just a cusp, overlaying that fractured cusp again or cracked cusp. Put a sedative dressing, and definitely either glass ionomer restoration or even composite, bonded composite, to try to retain the tooth. I'm a bit more hesitant than jumping the gun and doing a crown prep on that appointment, because there's a bit more thermal stresses that you sort of applying to the tooth, and I don't know if that reversible pulpitis is going to settle or convert to irreversible pulpitis. And if the tooth is and then we can recall the patient, and normally I'd like to leave them for about 3 to 6 months and then reassess, and if that has settled, symptoms have settled, then I'll be a bit more confident going ahead with a definitive crown restoration. If the tooth is non-restored, sometimes what I do is cut off an occlusal cavity and place a composite, or reduce the occlusion and place a composite overlay over it to try to embrace the cusps and also bond where that crack is, and again wait for the symptoms to resolve and reassess. So recall the patient again, and if it's symptomatic, whether that symptoms have deteriorated or whether we need to wait a little bit longer for a solution of symptoms.
Yeah, terrific. And now and finally, we're going to have again having even more worse a scenario, which is now the patient is showing irreversible pulpitis. And the periodontal probing depth is now at 5. There's a discrete, shallow-ish pocket of around 5 millimeters with bleeding on probing. We get those ones all the time. And we're not endodontists here, but assuming that you are going to cut an endodontic access cavity, what might be some of the things that you'd be looking for in those cases?
I think you skipped a few scenarios. But,
unfortunately, we only have 2 hours tonight. I would love to have 5 hours on this topic.
I think the governance, to cut my perspective short, if you have irreversible pulpitis and actually favorable pulping depths, it's probably when I'd say send to the endodontist to actually explore relief of pain, but also be able to internally inspect whether there is multiple crack, extension of the crack into the pulpal floor or reticular crack, because these things will dramatically reduce the prognosis factor of the tooth. If in fact on the other hand side, they have endodontic symptom, and I already see a periodontal probing depth of 5 millimeter, 6 millimeter is the cutoff, how are we reading this perio? So 6 millimeter pocket depth or beyond actually indicate from an external perspective that this particular crack is way down the side of the root. So that in itself, it gives a suggestion of a more unfavorable prognosis. So, while I would still talk to the patient about all of, if you can't make up your mind, we still got to address your pain. We can still look at things internally, but I can give a fair call to say it really depends now. It's quite unfavorable looking at the periodontal involvement, and carry out that conversation towards possibility of removal versus endodontic and pros with an unfavorable prognosis to begin with. So yeah.
So having that conversation of potentially maybe even the extraction of the tooth. Having the extraction.
Yeah.
Okay. From a restorative standpoint, would you guys do anything differently to a conventional crown, say, in that scenario, assuming that that there is a crack now actually in the radicular system? But the patient is quite adamant and really prefers to quote unquote save the tooth, right? We will have those patients. They are reasonably realistic, knowing that I understand that tooth is not going to last me forever. but I want to do my very best and try to save it. From a restorative standpoint, would you do anything differently to teeth in this category than the previous situations that we discussed?
I mean, in this case, if the crack is there, I mean, that obviously we don't want to make the crack propagate further. We're hoping not. So we always try to do what we call more bonded restoration, whether it can be a bonded composite core or a bonded fiber pulse if there's reduced tooth structure. And then, of course, for the final crown would be as much ferrule as possible in those cases. Yeah.
Great. Zoe, would you do anything differently?
Sometimes, apart from referral to an endodontist for the endodontic treatment for sure, and I'll be so say on that session, the patient came and we opened up an access cavity. Not that we will.
I haven't picked up a K file in the last 15 years. I wouldn't even know the difference between a K file and headstone these days.
But if the patient is in severe pain and they walk through the clinic and you had a look and the crack is actually extending to the floor of the pulp, I mean, is that putting the tooth at? Would you recommend? All right, this tooth looks like it has an unfavorable prognosis. Perhaps. Maybe taking some photos and showing the patient, discussing the option between taking that tooth out versus referring to an endodontist to do the treatment and further assessment of the propagation or the extension of the crack. If the endodontist have declared the tooth from an endodontic perspective a tooth that can be treated with a reasonable, some sort of a reasonable prognosis that the patient is happy to accept, then from restorative aspect, definitely a crown restoration in this case will be indicated to try to preserve the tooth for a number of years. It's not going to last, of course, a lifetime, but maybe if we can get 5 or 7 years out of it, that would be perhaps indicated to the patient that don't expect a great outcome, but at least we can preserve it for a number of years until it's gone.
Definitely, yeah. Mm-hmm. So we certainly have to reduce the patient's expectations in these final treatments. Absolutely. All right. So a lot of the things that we've previously covered in the upcoming next sort of half an hour, we will be in a more formal manner covering all these points. So we've discussed a lot about different, whether it's an onlay or crown. So Agnes, could you take us through the different restorative designs that we could consider for the restorative management of cracked teeth?
Okay, so a lot of the questions that I do tend to get from the colleague is when they are dealing especially early pickups of crack, whether they can do partial bonded restoration or does it have to be a full coverage crown. So let me go through a few concepts and take you through some simple ways as well in that early management phase. So if we look at your classic restoration, I've got a crown, an inlay, an onlay, and an overlay. So, sorry about that. When we look at centric occlusion on these, we really have to think about this restoration now have another purpose. They are not just replacing unfavorable tooth structure. You're also now using them to manage a crack. So rather than just looking at the resistance and retention form of this restoration, you got to now look at it at a point of view of immobilization of the tooth segment. So therefore, in this picture and all of them, you got to put a crack in place. Arbitrarily, that's the red line that you see, in the middle. So when you have a crown restoration in centric loading, it is sitting, it is bracing. When you have an inlay, provided that the inlay is being sitting on a nice sound cavity floor that you have prepared on either side, it could also be seating. In an onlay situation, got to be mindful depending on where you choose the bevel it is actually seating centrically, but also potentially very easily loading on the cusps. In overlay, you are seating and while protecting those cusps. It is more important when looking at these factors about any lateral loads. Preferably is no lateral load, but if you were to load these restoration in a lateral manner, and many a times they do, especially in certain strange parafunction that is not within your functional envelope when you are disclosing. In a crown situation, it will brace. It will challenge the resistance and retention form. But by prescription, you are wrapping and bracing the tooth together in terms of the immobilization of the tooth segment. In an inlay situation, depending on the depth of your inlay, it will create a beam movement to have a bending force on that underlying cusp. In an onlay situation, it have a little bit of a bracing, because in this situation, most of the time, you may actually change that functional angle to be a little bit more shallow. However, in the end, the cusp is still not yet protected. So it doesn't cancel out totally this lateral load. In overlay situation, you can see that there is some indirect retention and bracing offered by the little bit of cuspal protection that you give, even though it may not be all the way to the CEJ. It's very important to describe this because I can see why, especially if the tooth is vital. There has been many that will consider a bonded restoration for management of these teeth as a rather conservative suggestion, and it is, and in many ways. But I have to take this opportunity to stress in terms of when you hear people say, oh, yeah, it's that old amalgam, let's change it to a composite. A lot of the literature that claims the success rate, for example, this Senior et al. Back in 2007, if you're going to look at this literature, the main point that I want to bring out is they did not merely just replace that class 1 amalgam or that class 2 amalgam with the same class 1 or class 2 composite resin by beveling the caval angle. This particular author actually have prescribed how he had used indirect composite resin, and this is how he would prepare it. In fact, it is a full onlay restoration with full cuspal coverage, and hence the success that he has reported. It is so important to demonstrate that even in laboratory study, this is a lab study from Manier that compared conventional composite resin versus fiber reinforced composite. But it is an interesting study that I want to bring to your attention on today's topic, because in this particular study, what they have found is that, of course, the fiber reinforced composite can increase the stress the dissipation, as well as increase the fracture resistance in terms of material. But what significantly protect the cusp from fracturing, and what significantly increases the fracture resistance, is actually the restorative design in both category of cuspal coverage. And whenever we have increased fracture resistance or increase the strength of material, so it means you need higher forces before the fracture happens. It makes sense that actually it directs the fracture more apically instead of more following the horizontal vector of forces. So in many of these cases, while it takes more force before fracture happens, it does direct it more towards the root apex, apically, and it can be a bit more catastrophic. So to illustrate to you what my initial approach on some of these cases, so if typically signs of the first scenario that Dr. Lee had proposed, very obvious biting and releasing with the symptoms of the classic crack. Vital pulp, healthy pulp sign, and you have your amalgam restoration in place. You can offer the patient a renewal in view of the aging amalgam restoration, the crack within the amalgam restoration, and presenting symptom. We would remove the restoration to explore and to actually visualize this crack that is not only on the marginal ridge, but running along the floor of the cavity. You can see here that I have only very lightly prepared the occlusal surface for the overlay of the restoration. It does not have to be your classic 2 millimeter reduction in a crown prep or anything like that. It can be very conservative. And in the view that we are bonding on enamel, the more the better that we stay within the enamel. So then we replace this restoration in composite resin. And this particular girl was only 19-year-old at the time. We got immediate resolution on the pain and biting within a couple of days. She continued to remain symptom-free over a 2-year period. It is up to her now to consider whether she would like to have a crown. In this scenario, she is still relatively young, and she's quite happy with her restoration and how it's lasted. So this composite resin remains for the time being. This is the case study that I want to share with you in terms of my mention earlier on when we spoke about craze lines that we identify, or fracture planes, the stress plane, how it relates to our restorative design. So in this instance, the patient's already on impact, fractured the tooth. It's not complicated, does not involve the pulp. The restorative dentists originally have attempted several times to place this restoration. And while the shape and form was ideal to the patient, it kept debonding. So it was referred to me, and I think it's a very nice case story to share. Oftentimes when we decide to help, especially a young person, and we try to be conservative, and you think in this case, plenty of enamel to bond to as well. The restorative dentist had only very lightly prepared following this fracture plane on the tooth for his composite restoration. And married up with a patient who does have a parafunction as well, that was not really picked up. That's the reason why he keeps shearing that restoration off, because now the fracture plane is the previous restoration's adhesive interface. And every time he bites together, he is challenging this adhesive bond at that 90 degree. So that is 100% shearing action happening to this interface. Especially when he then goes to a protrusive excursive movement, it basically is a recipe to debond the restoration. Situations like this, what we think about doing is essentially I created a longer bevel. I basically also sandblasted the whole surface so that it is a more seamless margin around this whole new veneer that I placed. It was done freehand, so in this situation I was aware of that excursive movement, not your classic protrusion on that you see when I check the right excursion. I also check it to the extremity to just ensure that that functional angle marries up. I deliberately built out that distal incisal corner so that when I go to adjust the restoration, and if you look at the diagram, the little red dot is where he bites in centric occlusion. Commonly, when people pick up their burr, be it a white stone, that is the cone shape, or other burrs, they do tend to just keep reducing things in a flat plane. And sometimes in so doing, all that beautiful anatomy that you have created and that incisal length you created is now a bit compromised. So my little tip here for the audience in this scenario is to use a football. And you can see where I've placed that football in that diagram. The whole aim is just to give it a little bit more freedom initially and have not the functional angle not so steep. So that is why we would do that. And we must take into mind the excursive angle, the forces that are on the new restoration if that next patient walk in with that anesthetic craze line and you decided, okay, I'm going to do all these veneers. Bear in mind where those previous craze lines once were, as they will be the potential challenge to your next bonded restoration. We do have to think outside the scope sometimes. This is another case of incomplete fracture in a young girl on that tilted upper molar that you see. Because of the way that it is occluding, there is a point of interference and hyperocclusion of that distal marginal ridge, and we were able to produce the symptoms. It was reversible Potres. And when we think outside the box, it was previously unrestored. What we do here is we already naturally have the restorative space. We only have to do minor occlusal adjustment towards that distal marginal ridge. We have all that additive space to place the material, to splint the two parts together, as well as in doing so, reduce that functional cuspal angle to provide a flatter occlusal plane as well. So, there are a lot of things we can do when we're able to actually identify the types of forces that are on the tooth. And the important thing is not just placing the restoration, but how we then go about to finish or improve on that occlusal scheme.
Thank you so much, Agnes, and those composites are absolutely beautiful, masterfully done. Johnson, can you talk us through in terms of using indirect restorations? Right now that Agnes has covered using composite, using some direct restorations, what are some of the options and outcomes if you're going to use indirect restorations to treat teeth with cracks?
And endodontic basically indirect restoration on vital teeth is basically you have your onlays, overlays, could be gold, could be ceramic restoration, or could be crowns. So it's very important to show you keep the vitality of the teeth. But what I want to focus on is the survival of the endodontically treated cracked teeth with teeth. And in this case, Zoe has mentioned that the overall survival in 5 years, 84%. So it is reduced compared to endodontically treated teeth. But what's interesting is it's very important to have a protocol or what you call a team approach, where in our case will be the endodontist, the patient, and ask the prosthodontist. But in your case, you may be doing the endodontics. So there are some special considerations. I refer to this article because this article is very interesting. So for endodontically treated cracked teeth with radicular extension, most papers reported 80% survival, which is a 5-year survival, which is significantly reduced. But this article, although small in number, but they do show a very interesting protocol, and they show a 97% up to 4 years survival. And I will discuss how important it is to have a strict protocol to ensure the survival of endodontically treated teeth. So what they do is they remove the gutta perca 2 to 3 millimeter beyond the radicular crack. And what they do is they do an orifice seal, or basically what they do is they do a bonded restoration to ensure they split that crack or it doesn't propagate further. So hence, and then what they protocol is they do an orthodontic band and to ensure the patient is on board. They have post-op instruction to avoid functioning on the tooth, and also they crown the tooth as soon as possible to ensure they have the best outcome. It's easier said than done to replicate. It's basically you need to have a very studious patient that they basically book all their endodontic appointment and then book the crown appointment with you as well to get that done within that 6 weeks period. And what we believe, when we do the restorative procedure, is to have a bonded core or post rather than using cusp post and core, and then a ferrule as much as possible. And what they find interesting in that study is, it's quite interesting, and the endodontist checks the occlusion. So they found almost 80% of the teeth require occlusal adjustment. So hence, in order to have a very high survival, is highly reliant on the endodontist to place an orthodontic band, not just to splint the tooth, but also during that period, the patient may have accidentally bite on the tooth, and that may break the tooth, which we see a lot of the time. And for the endodontist to ensure the tooth is out of occlusion, for the patient to arrange all the appointment and also ensure that they do not function on the tooth. And then for us as a restorative dentist to do a bonded core post, as much ferrule as possible, and also very importantly to check to ensure the occlusion is good, having a shim stock clearance. But of course, it's also important to know there are also risk factors that could affect the survival. One, of course, is bruxism. So all of the patients require to have control daytime bruxism and also nocturnal bruxism as well. It's quite interesting. The reports reported that it's only 20% survival if they don't have a definitive restoration. So if the patient does not have a restorative restoration in mind, then basically it's a very poor chance of the true survival. Having a post affect the survival as well is basically a structural compromise, and then a terminal abutment as mentioned by Agnes and Zoe. Radicular extension, so we bring down the survival to 80%. I would still, when there's a radicular extension, I would still warn the patient. That article was, they rely on the patient and to have a very, very self-conscious, and then also they have a very strict protocol as well, having multiple cracks, and of course having a probing depth of more than 6 millimeters. At the end of the day, it's a discussion between you and the patient. Some patients are very risk averse. They prefer to do something that is a more higher chance of survival, and some patients prefer to keep their tooth as long as possible. But as long as everyone understands of the pros and cons of each option, then I'm quite comfortable of the choices by the patient. And then now to illustrate the case, we have a tooth, endodontically tooth that suffered coronal fracture. In this case, different options were discussed, but what the patients decided was to have a crown. So we went through the option of no treatment. Crown lengthening for front tooth is not a viable option. That would create quite a bit of aesthetic disaster due to gingival zenith asymmetry. There's an option of orthodontic extrusion, then restore. It does take a bit more time, and then of course your restorative the margin, the tooth will appear a little bit narrower because the root more apical is a bit narrower as well. Extraction without replacement. So patient is in the early 30s, so it's not ready to lose this tooth yet, or restore with what we call the long bevel subgingival margin. So this case was beautifully done by Dr. Lee again. So he first placed a fiber post and also a composite core. If you don't have ferrule, basically when the patient bite into something reasonably hard, a nut, your crown will snap in half. So what we rely on is this long bevel 360 degree. Because the root is thinner, so we prefer a long circumferential ferrule of more than 3 millimeters. It's very important to capture this margin. So to do this, we use double core retraction technique for 000 and then 0 until we retract the gingival, and then it's a 15 minutes procedure waiting for the gum to be stretched. And Dr. Lee took a very nice impression. Temporary crown, and this is what the patient mentioned. She doesn't like the notch, so the final crown was done without the notch. What's different about this is the patient needs to understand that there will be a little bit of a gold, usually 2 to 3 millimeter subgingivally, but of course sometimes there's could be some recession for some patients and not for others. And it's very important for that the contour, survival contour, to have a bit of cavity in there to reduce the incidence of recession. And this is the beautiful final result. This review photo was done a few years after the crown's place, and now it's up to 10 years result. And as you can see, traditionally we think that would violate the biologic width. But of course, I mean, if you have an excellent fitting crown, then the gingival response is very favorable. And this is the X-ray just showing the difference between the long bevel crown and the pre-existing crown of the patient.
Thank you so much covering that, Johnson. So Zoe, do you mind just sum up for us, after our whole discussion today, ultimately, what are we trying to achieve at the end of the day for cracked teeth?
So the ultimate aim will definitely be to prevent any catastrophic outcome, which is ending up with a tooth that we cannot maintain or we cannot restore with either endodontic treatment or a restoration or a crown or a post and a core. So looking through just a recap, what we've been discussing, it all depends on where that stress plane or the fracture plane may be. Which might be extending supragingival or subgingival. Is it affecting the root? Does it extend to the radicular space? All of those will definitely affect our restorative outcome. So our aim of management is to prevent flexion of the cusp, and we can achieve that at a provisional stage by using an orthodontic band. We might achieve or use composite resin restoration or temporary crown, and that can be also used to then confirm our diagnosis of the presence of a crack. Once the diagnosis is made and the provisional phase is done, then we can decide with the patient on definitive restoration. And you could go with direct or indirect restoration that will have or provide some sort of cuspal protection. Okay, and now we're looking at, I've listed here a few studies, and I think from my understanding, going through the literature, a lot of studies that had different study protocols or different study designs. Some were prospective, some retrospective. They had a variety of teeth that they looked into cracked teeth, and also different follow-up periods. Some were ranging from 1 year, some has 5 or 6 or 7 year follow-up. Overall, as a summary, all those studies looked into teeth that had or presented with cracks, and they had reversible pulpitis, and they used different restorative protocols in terms providing some bonded amalgams, pinned amalgams, composites, crowns, overlays. The different restorative material were used, and generally the survival rate was reported to be quite high for teeth that had cracks. Some of them had 93% to 100% reported survival within their study follow-up period. So all teeth tend to, or majority of teeth tend to survive. The difference is the reversible pulpitis had progressed to irreversible pulpitis and required endodontic treatment in a variety of cases ranging from 10% to 20%. So as long as we warn our patients that we know that those teeth may, even though they are favorable at this stage, we don't know how far that crack propagate, and we can provide all different restorative procedures, but be prepared that this tooth may require endodontic treatment, and we have to do a regular follow-up and reassessment of those teeth, and perhaps consider some sort of more warn the patient that whatever they invested in at this stage, they may need to replace or redo in the future. So to recap our prognostic factors, looking at endodontics, is the tooth vital or non-vital? Obviously, that will dictate how well the tooth prognosis will be. If it's non-vital and require endodontic treatment, certain techniques, and I'm sure the endodontic colleagues, they prefer thermal condensation versus lateral condensation to prevent the crack propagation. And again, looking to seal, providing a quick coronal seal within that 6-week period in terms of a definitive restoration to improve the outcome of the tooth. Ensure that there's a flatter occlusal plane in your occlusal design, reducing all these lateral forces that might be contributing to the cracks. And also what dictate our prognosis is how far that crack goes along the root. If it's multiple cracks, we know that it has, or involving the root has a more compromised outcome. So in terms of restorative design, usually try to preserve as much tooth structure as possible, perhaps utilize rounded internal line angles to prevent any sharp corners that will lead to stress propagation and initiation or propagation of that crack. Avoid using those cracked teeth as a strategic abutment for your bridge work or other strategic abutments, and optimize posterior support to provide enough occlusal units so this tooth is not being the only long-standing tooth that's taking on the occlusal load. Provide canine guidance, so there might be a need for some sort of occlusal adjustment. And again, consider controlling of the risk factors in terms of educating the patient who may have a clenching habit, or they may be biting on hard things, and if there's any parafunctional habit that we detect, maybe recommend an occlusal splint to prevent crack propagation in other teeth. So always warn the patient that prognosis actually questionable at best. And we may require endodontic treatment, and there may be complication with this tooth. Even though we try to preserve those teeth with our restorative management and endodontic management to prolong the life or longevity of the tooth, cracks, despite our best effort, may still propagate, and it may lead to a failure or loss of the teeth. So preventative strategy and control of the risk factors are paramount. Thank you, Ben.
Thank you so much, Zoe. Well, it's that time of the evening again where we're going to sum up. So once again, we're just going to go around the group for any concluding remarks. Agnes?
Okay, I think I have two brief ones. One is one thing we haven't really quite come across with the message is, what about those cracks that you see that are not symptomatic at all, and they're just there, and just as in our prevalence study, they're widely reported. And a lot of people might say, you don't need to do anything. And, while I do agree with that to a certain degree, it doesn't mean you absolutely just sit there and not do anything. I do think that it has to be noted. You certainly then have to check in the patient's functional occlusal scheme, or strategically how this tooth is being involved. We have to acknowledge the fact that it may be asymptomatic because of two possibilities. One is that it's really okay, I'm doing fine. The two is actually the nerve could be quite sclerosed or is already necrotic, so it is therefore, even though there are bending moments, it's not actually producing any signs. So wherever this tooth is maybe critical in the future of the occlusal scheme as a whole, or as you plan your rehabilitation, then it may warrant some exploration or some elective protection in those circumstances. But in a nutshell, though, once there is a crack, there is a crack. And I hate to say this, but I guess I have to do it, with time of COVID. All we're doing it's just a layer of protection. The crack is very much still there, but you will consider that protection anyway. It's not a elimination of the crack. So
vaccination.
No, so I think it's very important to outline it. A lot of the times we talk about indirect restoration to our patient as a more durable alternative. And in a sound tooth, it is. And to many common expectation of patients who walk in, especially without too much dental knowledge, they do think somewhat, I've got a crown, it's invincible. So it is very important that when we are proposing crown restoration to a cracked tooth, however, that we make it clear that this tooth is very much still very vulnerable. It is not a crown that we place and you can go and, do all sorts of things in the chewing habits or the types of food. I would approach that conversation quite differently to tone down the expectation if the crown is there because of cracks.
Fantastic message. Johnson, how about you?
Yeah, I think it's important for the patient to know. I mean, there could be a number of unfavorable outcomes. I mean, even monitoring the crack could worsen, and there could be symptoms. If we decide on management, there could be the need for root canal treatment, or during the root canal treatment, the crack may be so extensive that the tooth is not salvageable, and even with placing direct or indirect restorations, is always a tooth that they always have to be aware of, and with a bit of a compromised prognosis compared to normal tooth.
Absolutely. And how about you, Zoe?
Okay. Well, I think it's important to look into I think Agnes mentioned the occlusal factors and assess why the patient is developing cracks. So any preventative strategies are important to consider, changing of habit, lifestyle. But looking at all the studies that we've gone through today, I think definitely if we notice or detect a crack in the tooth, it doesn't make the tooth hopeless, and it's not going to go down in the bucket. But we know that perhaps it may provide the patient with an alternative option to implant in terms of trying to prolong the longevity of this tooth, even though we cannot guarantee that this is going to last a long period of time, but at least it may be just sufficient for extending that longevity for a few more years until the patient is ready for a replacement. So just prepare them mentally. So keep the patient involved throughout the treatment decision, and then we have the different options to consider.
Yes, make their expectations more realistic to manage going forward. Personally, I think of all the hot waters I got myself in with treating cracked teeth is usually I sort of jumped the gun. I think I didn't provisionalize the teeth for long enough. I didn't nurse the tooth for long enough. I sort of make the diagnosis perhaps a little bit too quick. So today, I think whenever approaching a tooth, particularly with some sort of pulpal symptoms, I think my recommendation would be to provide a provisional restoration for slightly longer periods of time, and just to reassess it for longer. In other words, you may want to place a good composite restoration, or you may want to place a good temporary crown, and just sit on it. Inform the patient that sometimes pulpal conditions do change as a result of treatment, and that's why that restoration is ideal for it, so that you can provide root canal treatment through that restoration, and then further visualizing the extent of the crack before you provide the patient with a definitive restoration. If there are crack lines visible on an asymptomatic tooth, so which is the one that Agnes just said.
I anticipated.
Yeah, I know. Would you consider cusp coverage restorations?
So I hope that my anticipation actually answered your question already. With asymptomatic cracks that we do identify in molars, bear in mind they are there for a reason, and there is certain fatigue within those tooth structure. But the timing to intervene would be dependent on the patient's presentation of, your full assessment of their occlusal scheme, and also, things can change along the way. There is a very, very classic example of, I'm sure many of you have seen this as well, where patients have a very strong functional cuspal angle. Their mouth is just full of class 2 amalgams, and they're all staring at you to cuspal coverage me, and yet that patient just have never had a fracture. It's almost like a disbelief that you just want to put every single crown possible in me. And sometimes, being a specialist, I'm not the first one to suggest it to them. And I would say to them, I'm possibly not the last one either. But my approach is I would explain to them, as they age, however, two things will happen. Their protective occlusal scheme may be wearing to become more like a grip function at some point. And also, if they hit that clock, that I'm joking, but there's no expiry date when you turn 55. But the truth is the tooth structure can weaken over time. And then when they experience their first cuspal fracture, then there's a sudden point of realization, and then there's this sudden urgency to crown the rest of them. But I guess what I'm alluding to is, this is just one example. But then there are other situations that I have mentioned already. If you feel that tooth is very strategically important to that patient, if the patient is now going on IV bisphosphonate, and this multiple crack tooth that you see is actually a 6. And this is, even as they age into a shortened dental arch, a key tooth that you really want to keep. Then it may be something that you would discuss with the patient, and it wouldn't be just a discussion on just that one tooth. I want to just get this crown unit out of it. There will be those reasons and those thoughtfulness behind why you suggest to look at something a little bit more durable and to the longevity of that tooth. So those would be my answers. If you have an asymptomatic tooth that you otherwise, otherwise if it still remain protected, it's been there fine. I wouldn't harp on it to feel the need. Just remember, there is only value into the dentistry you provide when the patient sees value in it. So I think that is a very important message.
Yeah, thanks so much, Agnes. There's a question on cusp, posts, and cores. Obviously, these are usually made using very rigid materials. Would we recommend them? And to reduce chance of future crack. Anyone want to have a go at that?
Cusp, post, and cores are indicated in cases where you have lost a significant amount of tooth structure and there's no more retaining axial walls to retain your core. So cusp, post, and core provide the stability, engaging the root as well as the pulpal chamber, and reinforcing your crown restoration. So it is indicated in cases where there's no other treatment possible. Although those days we might elect to go for a bonded fiber post that might be less stress distributing to the tooth when we compare that to the cusp, post, and core. But cusp, post, and core is definitely an indication in a molar situation where we really need to rebuild that tooth to provide a foundation for the crown.
Fantastic. For bruxers, we in our practice and right around the world, there's a lot of bruxers that's of course causing these cracks. In terms of materials, any recommendations on the indirect restorations? I guess metal, full metal, PFM, zirconia. Johnson?
Yep.
Any preference and why?
Provided the patient is okay with gold, which most patients are not, then gold is still have the least way. Zirconia is used very, very commonly. They can't go very subgingival, so they can only go slightly subgingival. It's gained a lot of popularity. People like to use a monolithic zirconia occlusal, provided occlusion are controlled and well polished. The zirconia material is well polished, and that is okay. PFN, some people can chip their porcelain, so some people are hesitant, but the chipping rate is very low. But ultimately, the control of the bruxism comes from controlling by the patient and also use of the occlusal spring, because although the material can be a design, but as Dr. Lee has mentioned in previous seminars, they can crack the root, rather than chipping the porcelain.
I think that's a good remark. Maybe we had to cut down on our slides, but it brings out a point where unless you address the parafunctional issue or the forces factors, I think there was earlier an X-ray to show that instead of cracking the tooth, the patient continued to actually have a broken abutment screw as well as a fracture on the tooth in front of it, of that unit. So, all that mechanical risks are still very much there. That is, I think, why we need to look at those risk factors and the etiology so much. And when you complete the restoration, instead of just thinking the type of restoration and what we're going to provide, more importantly is actually how you're going to improve to reduce that flexural load. In terms of all that prognosis factors, that all the 7 factors that Zoe had gone through, they all have just one message, and that is to reduce the flexural load on that particular tooth or other teeth.
Here's an interesting question in a scenario that we haven't covered, which is a lower molar. They found a crack in the tooth. They place a lining and then a composite overlay. I assume it's a full coverage overlay. However, there's still pain on biting. So despite that management, what should you do next? Zoe?
Well, I think one of the studies I came across actually reported that they did up to a 7-year follow-up on teeth that was restored post with reversible pulpitis and cracked, and they were restored with some sort of a coronal or composite overlay, and they found that 25% continued to be symptomatic at 7 years. And a large proportion of them, actually 50%, were symptomatic within that 1 year period. So having managed the tooth and conservatively, like this case that you mentioned, Ben, I think that's definitely looking to, so if the patient continue to experience reversible pulpitis symptoms. So it's important to distinguish that these symptoms have not progressed to irreversible pulpitis. So it might be continually symptomatic because the pulp is deteriorating. So certainly have maybe an endodontist to assess whether this tooth is vital or do we need endodontic treatment. If they assess the occlusion as well, so the pain might be coming from a spot of like a pressure point on the tooth in excursive movements. So take that tooth slightly light in occlusion and lateral excursive movement as well. And inform the patient that perhaps we need to follow up that tooth for a period of time, as opposed to deciding on the next step of restorative management. So if the symptoms has not deteriorated but they're still there, we know that they can persist for a period of time. So it doesn't mean that early management will eliminate the symptoms.
Yeah, and I think that gives actually a very important message, especially if that symptom continues. The last thing you want to actually is to do something indirect and irreversible. So when you are talking about a very large amount composite restoration in this scenario, a couple of things that I have to be mindful of. So are you bonding majority on enamel, or is that actually a lot is on dentin? During the time of placement, how did you control the isolation or the curing? Is there any technical post-operative sensitivity? When there are pain on biting, that's why taking that pain history is so critical, whether it was actually pain on release of a bite initially, but now has that character changed because of perhaps just being in a very large composite restoration that's been placed. So especially if there is any shrinkage issues or any pain on biting that is related to post-operative sensitivity of the composite resin. Have you perhaps the next point of call is your own review in terms of the technical placement of the restoration. If all the boxes are ticked, then probably the next thing I would ensure to do is not to go any more invasive, but rather is to ensure that to take that tooth out of occlusion. So sometimes you, as I mentioned, if you just look at that functional envelope and you just look at things, you screen tap, 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 and grind side to side, it is, just within that normality that you think you'd check. But in patients like that with persistent pain, I would probably bring them in to ensure that this tooth occlusion is being well adjusted, so that on maximum clench, it's still got maybe a shim clearance on it. And when you're checking the excursive movement, it's asking them to clench and grind hard to each side to the full range of movement that they can do, just to really reduce any occlusal impact on that tooth, and basically ask them not to eat on that side for maybe 2 weeks and see whether there is any improvement in those symptoms. And you certainly do not want to recommend treatment unless that pain is actually diagnosed.
Absolutely. There's quite a few questions about, what happens, during. So I'll just quickly answer some of them. Once a tooth has a band on it, are you committing it to full coverage? I guess in short, yes. Is it okay to leave a crack in the margin of a crown preparation, or should you basically chase the crack, assuming all clinical probing depth is within 3 millimeters? I think it is, assuming that the tooth is asymptomatic. If the dentist is worried about the tooth is going to be becoming symptomatic, therefore requiring root canal treatment, should I just temporarily cement that definitive crown? I think that ideally don't make that permanent crown. Is to stay on the provisional. You can say cement the provisional using GIC. I've seen some clinicians do that, or even cement that provisional, a well-made provisional using resin, and just hold that tooth there for much, much longer before you make that definitive crown. If unfortunately that an endodontic complication has occurred while that permanent crown has just been made, you can certainly make your endodontic access through your temporary crown, and then core, and then still complete cementation of your permanent crown. There's a lot of questions on whether these webinar can be viewed later on. The answer is yes. We'll have them available on our website, www.sitpg.com.au. I think it's for dentist resources. So that will be available probably in the next week or two. The favorite, my favorite statement or question out of here is that don't worry, Ben. Most of the questions are from Mehdi, so you can ignore them.
He has been ignoring them the whole webinar.
Yeah, that's right. I knew exactly which ones Mehdi has been asking. Yeah, so the earlier question about the earlier case of 23627, where I completed ceramic inlay onlays. So the question was, why don't you just fully coverage all of it, both two teeth? I think that's certainly an option. For this particular patient, if you look at the cusp, they're actually not that well worn. So generally speaking, dental parafunction, it's not a significant issue for this particular patient. You note that he was in his, I remember, was in his 50s. His oral hygiene is good. He has some erosion facets, but other than that, the severity of the bruxer facets, it's not severe for his age group. Further, you don't see any lingual torides or any other issues. There was just a small crack that's suffering on that 3-7 mesiolingual cusp, which you can see it's one of the thinner cusps, possibly undermined by that amalgam restoration. So there's some restorative factors there to weaken that tooth, and that's why I felt comfortable at providing this particular patient with a ceramic inlay/onlay restoration as opposed to a full coverage restoration.
Yeah, and I think certainly if this scenario though, you can already have a visualized crack line that goes over that distal marginal ridge, that might change your decision making differently. But I believe in this case, when you remove the restoration and looking at it internally, you can track the crack along the pulpal floor, but not yet quite involving the distal aspect. So that was probably supporting the basis of sparing it. Yeah.
There's quite a few questions that they all sort of fall within the group of how long do you provisionalize or temporize for before you move on to a definitive restoration. Obviously, it's really variable depending on the condition of the tooth. But let's assume that the symptom whether it's pain on biting, whether it's reversible pulpitis, were successfully addressed, let's say within a couple of days, which is the majority of the cases we see. Under that circumstance, how long does the panel feel comfortable to provisionalize before you move on to definitive restoration?
Look, I often say to the patient, I acknowledge a lot of this research study design based on the protocol that they look at. They typically would review their teeth at 1 or 3 months and 6 months, and I think those timeline came from endodontic research journal that look at also pulp cappings. So looking at just that pulpal response in that time frame. And I would let them know that 20% going from reversible pulpitis to irreversible, it comes from a 6-month time frame. If they want to wait that, it is a good time frame to organize a review, just around the 6 month. If they want to embark on it earlier, really that elimination of symptoms, it does give that confidence level to address, to eliminate the symptoms. But that is not to warrant the no need for irreversible pulpitis or that endodontic address. So so long as that clarity is there, then you can do it sooner. If all the patients really value is just no address of symptoms and I just want to give it a finish here, understand, like, you know, some people are like that. But some people really focus on, I don't want to drill through that crown. I prefer if it has to. Then I quite frankly let them know better insurance after 6 months, but that's still not a guarantee. You know, we just have a little bit more confidence interval. That's all. So long as the tooth is alive, it's been through so much already, that risk is always there, but just more or less.
And there's also at least 5 or 6 different people ask the question that in terms of using composite resin restoration as a provisional at first, whether it's to address a fractured cusp, whether it's to overlay a tooth to management cracks. Can't you just leave that as a permanent restoration now that the tooth is becoming asymptomatic? I think the answer is absolutely yes. You can leave that as a medium-term restoration. We all know that composites don't last forever, and nothing lasts forever. So as long as the patient understands that at some stage there could be leakage, there could be chipping, could be wear and tear, that you need to replace the composite, whether with another composite restoration or of a indirect restoration, absolutely, you can definitely leave that.
So by that time, patients are very much educated. I would just let them know that the performance of the composite resin, as you would report, a posterior composite resin may it is reported a good success rate anywhere between 4 to 6 years, and they have to be particularly aware of the creeping back signs and symptoms. If that adhesive bonding from the composite, any marginal leakage from the composite resin, or they're getting that sense of pain on biting again. So on top of just looking at the marginal integrity of the restoration or the replacement need from that regard, you also have to screen any emergence of symptoms again. When you routinely check the patient, do your walking probing depth around these teeth with or without reported symptoms, so you can continue monitor any progression of those cracks and recommend accordingly.
Fantastic. There's one comment about would you consider relining teeth as opposed to selective occlusal adjustment? I don't believe we've advocating selective occlusal adjustment. So I just want to make that statement to the viewer. Maybe you've misheard us. We don't really consider that unless if we're talking about a single tooth that's in hyperocclusion. Yes, I think definitely you should control the occlusion there. But let's say for the anterior open bite case, so the significant anterior open bite, I would not carry out selective occlusal adjustment on those posterior. So definitely we'll be looking at orthodontic treatment for those. There's another viewer that had a concern that, well, if you're going to have a crack potentially that is subgingival and you're not really, I guess, eliminating the crack and eliminating it, isn't eventually bacteria going to get through that crack into the orifice? I think
the answer is yes.
Yes, absolutely, it could, and that's why we've said everything tonight, which is you need to warn the patient. You need to if in doubt, provisionalize that for as long as possible so that you can obtain a better definitive prognosis before carrying out definitive treatments.
And I think the critical message is we're not recommending crowning every single cracked tooth. We have covered the prognostic factor to discuss. So I don't think there should be a concern in regarding, like, what if this crack is so subgingival and we are not eliminating it. The reality is you can't really eliminate it. The only other option is if that tooth is really not restorable, then the patient may have to consider realistically having it removed. We cannot proceed to crown a tooth that has a very poor prognosis or not restorable. That is not our message at all. So we just have to be able to report on those findings. And if there is no periodontal involvement, so therefore not suggesting that the crown has propagated into the root area, then based on the prognostic factor and controlling all the risk factors, then I do not particularly see the need personally to try and eliminate the crack in itself.
Here's a really interesting question. For the final restoration of a tooth that has been root canal treated due to crack or fracture, should the ceramic restoration be extended into the pulp chamber? So this, I guess, it's like your CEREC endo mode type of restorations where they mill out CAD/CAM, I would think. And then they have a extension of that ceramic, that one-piece ceramic restoration all the way into the pulpal orifice. What do you guys think of that type of ceramic restoration?
Well, if it's in a crown situation, so if it's a ceramic crown that we're doing, normally in a crown situation, I would not be extending the ceramic into the pulp chamber. I'll be relying on building up a core and preparing the tooth as an individual crown. But if it's an onlay situation that you're removing the whole entire core and building up the tooth into the pulp chamber, I suppose the things that we can extend it to a certain extent into the chamber cavity, provided that we can eliminate any sharp line angles. So I don't see why not in an onlay situation, but perhaps provided that there's a rounded internal line angles, and you can definitely see it and gain some sort of retention from not just relying on the bond in this case, so you're getting some mechanical retention of the tooth as well. But in a crown situation, then that's a completely different concept. So
I think
in that case,
there is no absolute right and wrong, and I do certainly know of practitioners who do endo. They call it kind of like a endo crown.
Yeah.
And the reality is, in those endo crowns situation, you would not. So just for the audience out there, so this is when they extend the internal surface of the ceramic into the pulp chamber like an inlay, and then still have the external surface like an onlay situation of the crown. You do not then create a very deep step to get that external ferrule effect so much, because otherwise you really just have a very thin slitter of tooth, especially in the cervical area. It is certainly a technique that have reported different success. Some study has shown quite poorly, some sensitive, very technique sensitive in my opinion. You have to be mindful that in terms of looking at the internal core, just as I mentioned, going back to the basic physical principles of your material knowledge, is that when you provide something of a harder nature, increased fracture toughness, yes, it will demand more forces before that get transferred over, but it also often end up being a bit more catastrophic as well. And certainly in the occlusal scheme design, I think it can work so long as you know your critical information of how those resistance and retention forms are for that restoration, as well as how it relates to in terms of immobilizing the tooth segment. I would not recommend an endocrown at all in situations where you are leaving behind a crack, because it does tend to, if you look at the flexion of it, it's probably not so favorable. But in a non-crack tooth, certain scenarios, it may work.
There are quite a few questions. They all fall under the umbrella of asymptomatic cracks. Some of them asking how do you manage them, some asking if they are under pre-existing, very commonly amalgam restoration, you see a crack but otherwise the tooth is completely asymptomatic, how do you go about it? So I think we've pretty much covered that, which is we notice it, we inform, educate the patient about it, the presence of them, and looking at whatever other factors that there could be at play to try to mitigate future progression of those cracks.
If I'm seeing the patient for the first time and I see a very aged amalgam with some cracks around it, I will, and asymptomatic, I will not really just make a decision that they on that day it needs to be replaced. Those signs are not in itself spelling replace me. But if we know that those incidences that about 10% will have progressive symptom in that coming year or up to 3 years. And, you can, by all means, acknowledge and inform the patient and the fact that you are monitoring them. And then, as you see them again, or your reasons of when you will consider to intervene, mark them down. And there will come a time where, like, when you see those further indications, then you may then intervene early and intercept. I think, in short, that should answer most of those questions.
Absolutely.
Yeah.
So once again, to all the viewers that's still with us, that you're half falling asleep, thank you so much for joining us again this evening. We certainly had a blast talking about this topic, and thank you for the overwhelming number of questions, especially you, Maddie. So on that note, take care, guys. Stay safe, and wishing you and your loved ones all the very best. Until the next one, good evening and bye for now.